Let's begin. Welcome to the final Health Informatics seminar for this term. I'm David Potenziani and will be the host today. Please remember that today's seminar is being recorded. Do, if you're online, joining us, mute your microphone while we're viewing the presentation and hearing our presenter. However, when we come to the Q&A segment, do feel free to unmute yourself and pose questions or make comments to the presenter. Alternatively, you may post in the chat where I'm happy to relay and sometimes amplify your question or comment. So let's begin. Today we're going to hear about AI in human workflows from Professor Łukasz Mazur. Professor Mazur is in the Department of Radiation Oncology at UNC Chapel Hill, with a joint appointment in the School of Information and Library Science, and serves as director of the Division of Healthcare Engineering. A nationally recognized expert in healthcare engineering and management, his research centers on improving quality and patient safety through continuous quality improvement, artificial intelligence, and better design of health information technology. He leads a simulation lab that has completed more than 500 hours of experiments on clinician performance with electronic systems and artificial intelligence tools. His work is supported by multiple ARC grants focused on simulation-based training, cognitive workload in electronic records, and AI models to improve peer review in radiation oncology. Today, he is going to give us a presentation on moving towards better understanding of safe and trusted AI human workflows in radiation oncology. Professor Mazur.
Well, thank you so much for having me. I just want to double check that everybody can hear me okay?
Yes.
Thank you so much. Okay, so thank you for the opportunity to speak with you guys. And David, because I do hear myself, and I think if you put yourself on mute, then that will go away. All right, let me try. Yeah, I can still, I don't know if everybody else, but I do hear the background. Oh yeah, thank you. Perfect. I appreciate that. So thank you for the introduction. Thank you for the opportunity to share some of the work that I'm currently doing on safety and AI. I'm very excited. Thank you for being here. I know this is Wednesday afternoon, so everybody's tired. So I'll try my best to keep this somewhat interesting, hopefully, and entertaining to some degree, so that we can have a good dialogue. So I'm going to jump into the presentation. My slides will advance. Yeah, I'll be here. I got to do it on this screen. Okay, perfect. First of all, I do want to ensure that the work I'm presenting, it's truly the collaboration of many people, right? So I get to present today, share results, but really it takes a village to do this type of a work. So what I want to recognize clearly is just the team from our radiation oncology department, Dr. Marks, Dr. Anderson, Dr. Repka, for providing the clinical expertise, as well as Dr. Das, Dr. McGroog, John Dooley. These folks, are my colleagues within the department, and doing work in radiation oncology truly takes, all of these alignments to be able to get to the point that we are often try to get with research. And great collaborators from SILS and also from FSU. So we have Dr. Arcot and Sambit here that really provide a lot of background information about how to develop, design the AIs, and how to kind of get that going. I always am grateful for the work to my former PhD student Kartika Dappa, now doing a lot of work with WHO and really spearheading the digital health across Asia Pacific region. His collaboration and ongoing discussion is always useful. And a lot of work for this particular presentation really goes to my two PhD students, Elizabeth and Gloria, as they engaging with us and doing a lot of background and heavy lifting and a lot of this work. So just want to make sure you guys see all the faces behind the scene that really make this happen. Okay. Here's the agenda. I'm going to share some background information about the setup here in Radonc and how we, what we're going to do with the AI. We're going to talk about peer review process as a way of thinking about patient safety and how we are embedding the AI into that process, and really kind of look at the application, right, of this AI into the within the radiation oncology. So let's start with the background information, just to make sure that you come from a variety of experience and backgrounds. I want to explain. So patients come to our department, and the magic happens, right? This incredible thing that we have. I'm sorry, this moves too quick on me. And what is happening is that they go through scanning, we get the images, and as I'm going to be presenting today on these images, we have to counter, right, the target, which in this case, we are talking about prostate cancer. So you can see right in the center middle, we got to create these contours. We need to know where the target is because we're going to deliver radiation there, right? This force that's going to, kill the cancer. But at the same time, we have to be extremely careful, and we have to counter also other regions, the healthy, like the bladder, the rectum, the places that we don't want to deliver the cancer, right? And on top of this, you see that some of these structures are fairly straightforward, but we have that kind of bluish color there, and that's kind of the area of lymph nodes, and that's where the cancer also can spread, right? So as you can see, that area itself is a little less defined. It's a little more complex, right? It requires more intuition, knowledge, experience to be properly countered. So let's take a kind of a look here. I'm going to play this short video. So this is for example bladder, right? You could see how very clearly defined. But if we look at the lymph nodes around, right, this region, you can see in pinkish color, you can see that shape is much more complex. It changes, right, as we are moving kind of through the scans. And physicians are trained, of course, to be able to identify these regions and properly create the contours, where this microscopic disease could spread, right? So manually, this is the work that's being done by MDs, and then collaboration with the dosimetrists. These contours are getting created. So that will be our base for where we are applying, and we'll be talking about how AI can really assist us with this work. Okay, so there's some examples. Second is to set this up. We have what's called peer review. So all patients coming to our department, eventually where these contours get created through this collaboration between the physician and the dosimetrist, eventually before they can be delivered, we have a peer review. So it actually happens in this room as you see it. The cases are being displayed on these projectors, and we have this as a quality assurance step. All the multidisciplinary team of folks, right? Physicians, nurses, therapists, dosimetrists, physicists have a one more look, and they are encouraged to speak up, right? So a very important part of the quality assurance system is to actually conduct these peer review sessions, right? So historically, let's look at some data. And how what is the effectiveness of this type of a peer review session? So if we look at systematic reviews, which really looked at, over almost 100,000 plans that have been created over 10 countries, we are finding that about 25 to 28% of these plans had some modifications done, right? Following the peer review. So people find things, and there are some level of recommendations that things could be a little better, what we are intending to do in terms of the plan, right? 12% of these required some level of major changes. And again, it is the definition here. I want to warn us is not to take it that these are the word here, the use of it. There's a spectrum here, right? So I want to be kind of cautioning us that, it doesn't mean that there were some major mistakes, but major changes that can have some effect, right? Clinically meaningful effect that can do the plan could be better, right? In this case, if you look at large institutional prospective studies, and you look at the, a 13,000 or so patients, right? Curative intent cases, you'll see that 41% of these cases required some level of modification post the peer review. And the last thing that I want to say, if you take kind of this overall and summarize, we could argue that there's some level that the peer review is offering that 1 in 4 patients, we are making some clinically meaningful change, right? Again, it might be that, again, I want to put this in perspective that the word clinically meaningful has a spectrum, okay? and then prevent some potentially safety related deviation, something that would not be the best outcome, right? Not death-threatening outcome, but not the most optimal outcome, would be 1 in 8 patients. So it is, the peer review effectiveness and importance of it is important, right? So that's what I want to establish as I will, as I set up the work of how we embed AI into this work. Okay. So what are the challenges? You have a varying number of physicians or other folks showing up for peer review, right? So every day, people are busy. They have conferences. They have to come to the clinic early, right? There's a lot going on in the department's life. They also have been trained, and their experiences are different, right? So the way they think about nodal volume coverage and how to do it also is based on some level of, right, their preferences, how they've been trained, what is the current practice here within the department, and as I talked about, the elective nodal volumes are by nature difficult they're not the easiest to, there's a lot of complexity looking at the images and really ensuring that you understand how to contour that nodal volume. So you can see the radiation oncology field has decided to come together, right, with about 86 experts coming together and developing guidelines like atlases of how to do this, right? And they have been, published. And that's what we would like to kind of call that there's a level of standardization that can occur if we try to apply these guidelines and right. So as an example, you can see on the column A, so top left corner here on the slide, right at this, in this view on that slice, looking that there's a blood vessel, which again, you would have to spot and be knowledgeable, right? As a physician, that's a blood vessel that you should stay somewhere 7 millimeters of that blood vessel when you're contouring, right? And again, there's about 30 of these recommendations that physicians could apply for the best practice possible by the guideline or this, right? So the question is, if it's it's a difficult job, right? Can AI help here? Can we have AI assistance, right, in this field, and how would we do this? So that was kind of the question we've asked ourselves, in this project. So we called the AI, we gave him a name, we called him a jerk, because we thought the AI will always have an opinion because, we're going to teach him, we're going to train it, right? So he's going to learn from historical data of how we conducted, the nodal volume coverage. And our question was, if we have that opinion, how do best embed the AI into the workflow, into the system, right? I mean, number one, you could say that, well, let's give the tool to the physician, right? The physician that is now looking at the images sitting in their office, get access to the tool. It's really good. It actually can perform really well. They will, click on the button, get the contours, verify them, and we move on. Well, that's one way. That's one logic, right? There's danger that comes, as a safety person, I'm like, well, there it is. There's a lot going on here, right? Potential de-skilling, how do you trust it? You don't trust it, you're rushing. I mean, just that one step of giving the tool at that level. So that's one. Second thing would be, well, let's use it in a peer review, right? Let's bring it to the peer review. Let's make this agent, let's make this AI to actually be at the moment where we're going to put it in a peer review, and we can display these contours, what the human did. Great, they did the workflows. We didn't change anything. We're not de-skilling. People are still doing the important work. That's their job. We have to be doing this. And now we're just going to have a AI contours popping in a peer review, and people can do it, right? Sounds great, but the question is, in what order, right? We're talking safety. Well, in this moment, is it going to be, is it going to be displayed together? What type of an effect do we have on people cognition, on the workflow, when suddenly you are used to seeing human-generated contour, but you're seeing suddenly two contours, right? So these questions are a driver of this work, right? You got to really ask yourself deep questions. What is exactly happening when we're bringing AI to the table? So we needed to construct some experiments, right? So we started to do this work. And I do want to just mention that, if you look at what the consensus, we use this by the DICE score, is a measurement of how good, by a gold standard agreed in this, in this study, the panel of experts came together. They had cases They agree what would be the best, most optimal, right? The gold standard of this nodal volume coverage in the contours, and brought experts, and these experts would work through the cases and agree. So Dye's similarity coefficient is telling you how close the contours generated by this X came to the gold standard, right? And now you can see that one is perfect. In this case, through this workshop, kind of a gold standard out there, you can see was about 0.79, right? So what I want to kind of show you that our model, right? So the top you see our model is 0.79, so came to perform from the paper itself, right? From the papers you see at the bottom, the experts come to about 0.73, right? So this is just to give you a gauge of where the model performance to kind of an expert panel performance in case of doing this type of a work. So we got a good model, right? Decent, and we need to apply this. So first, let's find the baseline. In our clinic, how many of these issues with the nodal volumes do we really have at baseline in the clinic, right? So we reviewed 255 cases. In that range there you see, we learned that there were 6% of these prostate cases had specific contours, contour specific issues identified in peer review. And then if we look more closely, at this, 12 out of 15 spoke specifically about the nodal volume. And again, if you go even one step further, what changes have we made? You could kind of argue based on this analysis of the sample that in about 3% of cases, we clearly saw that during peer review in our clinic, we've made a recommendation to make some sort of a change, a major change, moderate to major change, into that contour. Okay, so that's the baseline. We're talking about 3% of the cases. All right. So now with this baseline in mind, we need to create an experiment, right? We need to study this topic. So I do a lot of simulations research. So what we are doing here, we have 4 groups. We're going to simulate a peer review. We're going to invite 2 MDs with expertise in prostate, one dosimetrist who runs the actual, right? They display the contours. They are kind of in front of the table, so to speak, driving the software, displaying the things. And we have one physicist because the physics eventually going to take the plan and construct it, right? They're going to do QA on the plan before it gets delivered to the machine. So we have 16 participants. We got 20 cases developed, right? That is going to go to the simulated session. So total number of assessments here with 4 groups, that's 160 assessments that we're going to do. We have 2 sessions. In session 1, they come in and they do the work they normally would, right? There's no AI assistant, no jerk in the room, right? So no, nothing. In session 2, we have AI assistant. So we are now saying you're going to now see 2 sets of contours, right? We're changing your workflow. We're changing kind of the dynamics of the meeting. On top of this, we want to make sure that, what we've done is that in session 1, we have 10 cases that originally was done by humans and they went through the peer review. So like they came from clinic, they actually were approved. And now we have also 10 cases starting where we used AI to generate, right? Because we're going to ask people to comment on these contours, right? So each team, as they go through this experiment, they need to give us the recommendations and they have to use specifically the word. I'm giving you a major recommendation, a moderate or minor, right? They had to be typed in the chat when they were doing this experiment. They had to actually specify this so we don't interpret these things ourselves. And on top of this, in a session 2, when they work with an AI, they need to tell us, which contour do you prefer, right? You just finished. Which one do you really prefer to move forward? And was AI and useful? All right, we ask these questions. Okay, so let's take a look at some of the results from this experiment. First, what I want to tell you that I wanted to make sure that people felt psychologically safe in these groups. So we asked them about validated, so did you feel safe psychologically, make comments and be in this group? And just very quickly, just both sessions, as you can see, yes, the results did tell us that people felt psychologically safe to collaborate in that simulated sessions because the scores, proved it. So that just want to make that point to you. We also learned that, when they coming in, what was their state of trust in AI? So you can see that based on these 3 questions in session 2, just gauging them, how much trust they have at this moment, based on their experiences of what they do. I mean, it's kind of, somewhat, between 3 and 4, right? So this trust is it's not, not the highest, so to speak. So they come with some background information about how much they've developed over time. It's early. I think in healthcare in general, we are still very early in absorbing AI, right? So I think this is a reasonable score. But I wanted to know that because I think their comments and the interactions and behaviors could be influenced by where they are on that scale. So let me kind of get you guys. I'm going to skip those because I have some new results, but I want to get to this point. So what I want to show you guys is that let's look at the major and moderate. The other slides were talking about minor, and there was a lot of interesting results which I'm updating. But when we come to these major and moderate changes that they recommended, right? When we gave them a human-generated, right, contours, which I remember already were clinically delivered. So they were one that you could consider that they were all set, right? We actually did that care, right? In session one, right, when we started with humans, in session one, they made on average between the major 1.2 recommendations per, evaluate per case, right? So that's about, right, about 23 of these total of these recommendations were made, right? Now we go into session two. Now they have two sets of content. So the AI is coming, right? The human generated and the AI, they labeled, they know what it is. Please note that in session one, they were blinded. They have no idea what they're looking at in this case. They just see one set of contours. They will have to assume they're blinded in session one to what they're seeing. In session two, by the IRB and regulations, just getting ready for clinical trial, I'm labeling them because I want to test this idea that now you're going to know. I'm going to let you know which one is which one. So you can see that, they do pretty much the same, same thing, not much of a change. And if you ask them, was it useful to show you the AI? In this case, 67% of these opinions are like, yeah, it was useful. But which one do you prefer? In this case, they only in 10 cases, they prefer the AI, right? Because, they prefer the human. And that's probably reasonable knowing that these were, delivered contours, clinically, right? So now you go in here and you start with the session where, again, they blinded, but we give them an AI generated one. So it's, it's a good model. But now in this session, you can see they are making 3 recommendations per case. So total 55. So way more. Now you can ask, does the group, do they feel it? Do they kind of see something is off, right? I mean, they're making recommendations, 55 of these. And then when you show them both, right, in session 2, and there was a period of about 3 weeks they would come between session 1 and 2. So for letting them, they're so busy that about 4 weeks later, they don't remember these cases. They do so much that's very hard, but there's some carryover effect clearly in the experiment that we can argue. But, in here, what you're seeing now in session 2, when they see 2 set of contours, they drop to about 2.2 of these recommendations. That's total 41, right? So now the question is it useful? 77%. Yes, it's useful. And, how often do they prefer would actually go with the AI? No, they said to a 12%, only few cases, they felt that, they would prefer to go with the AI contour and make those modifications, right? So again, they're still providing some changes, right? But this is their preference. So some interesting results. But what does it really mean? The question is like, how can we break it down? So we really have to look into clinically, like where are they making these modifications, right? And again, if you think about lymph nodes, you need to look that, they tend to, right? We tend to contour them around the blood vessels. So you have the blood vessels on the picture here. And, that shape is kind of interesting. That's why you see that kind of a connection and then this connection on the lymph node area. But so we're starting to say like, where are these concerns coming from, right? So again, on the top graph, you see on the y-axis, your number of cases, that these were made, and then you have these regions, and again, we don't need to clinically go, but different kinds of regions depending of where you are on the scan, right? Starting from top, you're going to the bottom, right? So in this case, you see that there's clearly that, that when you are, when we say too tight, like you contoured something a little too tight, right? Like that's the concern that they usually bring up, during these conversations, that it clustered around this external iliac region, right? In this case. So we are starting to look like, where are these recommendations coming from? And there's some consistency, as you can see, right? I mean, in both sessions, right? Session 1 and 2, kind of grouping it together, we're starting to understand that that's where the concern was for these cases. Then we're going to have to go and look at the too generous, right? You kind of like too generous. You're giving maybe your lymph node coverage is a little too wide, right? So to speak, right? A little too much. In this case, what we are seeing, like slightly different distribution, similar, but slightly different. And as you can see in session 2, you're starting to see a little less of these, right? Of some of these recommendations. And they starting to kind of go, in the area of bowel over inclusion, which is severe, high superior extension issues, right? So you're starting to understand kind of the regions and areas of how is that human dynamic, that conversations are taking place, right? When the AI comes into play, right? So we are analyzing that at this level. Okay. So when it comes to, so what does this mean? Right. So if we ask this question, right? So I got experts now, right? So I'm not clinically trained. This can mean a lot of things to me. So I'm starting to break it down, but I bring two experts, right? A prostate physician who's an expert in a field, and then we have a seasoned kind of experienced physician, but non-prostate to judge and help me understand how clinically meaningful these differences are. Okay. What is being said between this, with AI and without. So as you can see that we asked this question. So from all these cases, in this case, I'm doing this on a sample of 9 cases, 18 evaluations. And I'm starting to see that, that in session 2, right? Because you can see in session 2, because that's the only place where we have the AI is being used, that when the second contours infrequently alter clinical discussion, they not. However, when they do, the perceived impact was more often beneficial than that. And this is, again, and this effect was consistent across reviewers. You can see that if you see them like, was it clinically? Yes, they agree that in 7 cases, right? That in 7 of these evaluations, they say, yes, it was different, but was it clinically meaningful, right? Clinically meaningful. So if I think from my safety hat, right, from my perspective now, I'm sitting in front, I have a sample here, and I'm feeling that in 4 of these cases, right, that we are looking at it, both of the reviewers say that having AI does have a clinically meaningful, better outcome in this moment from that discussion, right, of what the recommendation is. Again, it's not necessarily a lot, but for those patients, it's critical, right? So it's starting to, kind of and I do want to kind of caution myself. I do want to caution myself that when I say, it's beneficial, the detrimental, it's preliminary, right? But I definitely feel like I'm starting to learn from this experiment that, getting things done with AI in a proper way can benefit some of these patients, and creating the agent in a peer review that can give us kind of their perspective and enhance our understanding of the guidelines, right? Because and understanding of how we are trying to standardize the clinic. If that's kind of the role of the AI, and it and it allows people to agree on some of these clinically meaningful changes, that there is potential, right? There's clearly a potential to say, you know what, for quality assurance, for safety purposes, an AI agent playing that role during the peer review could help us, if we do this right, kind of provide us kind of that level of heading towards some level of standardization. Right? If we do believe in the atlases and guidelines, and the AI can do this, and it's not saying that it has the right answer, that's not the point, but can guide us towards level of standardization and allowing still the physician to be in charge of the clinical decision making and allowing them to think critically and not taking the work from the workflow previously, meaning they still got to do the work, there's no de-skilling, and bringing that AI at the moment of you did your work, you presented your work, and now the AI agent comes and say, listen, I'm trying to show you how I would do this with respect to what we've been doing historically here, according to the guidelines. there is a possibility that I am taking a system approach and a workflow approach, which I can standardize and at the same time help some group of patients get right better contours. Right. So I'm highlighting this moment here that when I say that there's beneficial, I'm talking about beneficial with respect maybe to the overall picture of where we are heading with AI in terms of standardization, right? That I can't tell you it's beneficial to a patient right now. Yeah, there are four cases, right? But how is it going to be better outcomes? Is it going to be, less pain? I don't have this data, and that's not, I think, with the study cannot answer these questions. And I know I'm going a little all over, but I hope I'm making some sense to you guys. Okay, so let's kind of move on. And then, we ask also, did the second contour help identify new concerns, right? And again, I'm just going to point in 3 cases, it did, right? Again, so I'm going to say from safety perspective, if I put my safety, that's big, right? For me, that's huge, right? Personally, right? That it helped you kind of identify. However, that didn't come without risk, right? So if you analyze the transcripts and you really look at the dynamics happening in the room, you're realizing that, yeah, it's great that, we have some of these moments that, we're identifying these risks, but at the same time, having AI in the room, especially during the implementation efforts, early, before the maturity, before we fully trust it, before we've got our workflows ready, in this case, what's happening, you also know that AI did create a distraction, right? People were noticing it's AI, start talking about the AI, and that changed the workflow, that changed the culture, that changed the dynamics of the meeting. There was still the talk about the trust, right? This is labeled in session 2. Attention got shifted, right? We shifted the attention towards the AI, and there was tunneling, meaning what I've noticed is that when the AI has a problem, or there's a difference, we are tunneling on the problem. We're forgetting to have a holistic approach of review of what we are here to do. And I'm not saying that this will continue, right? I'm just saying this is a dynamic that's happening in an experiment. We just have to take the knowledge into the implementation and be aware and mindful of these dynamics occurring, right? And this is that moment. And again, why, and the last thing that I want to mention is, the AI was not preferred in many cases, even though sometimes it would be argued that was better, because we're still giving kind of the human the benefit of the doubt that the physician knows it better, right? So again, we have to be mindful of that as well, that the preference to go with the human generated might have a kind of a historical precedence, and then making the changes on versus, really trusting and saying, what, let's go with the AI contours and do the change. That this dynamic has to be studied even more, right? Moving. All of this is happening, right? In these experiments. All right, so I'm gonna, as I blabbed for about 30 minutes and I have some supportive slides, I wanted to, hopefully, inspire for some discussion. I would love to learn from you guys and kind of, get any questions, of course, any comments, but, workflows, systems, we bring in AI, to the healthcare environments. And I am, I'm kind of arguing for the amount of work that I think we need to do from a perspective of human factors, risk, implementation science, and in that blend of things, really starting to understand that we need to have a framework for doing this work. And I think this experiment is just an example of trying to do the diligence of work and really build confidence of what the workflow should be. Based on my study and based on this result that I showed you, the clinical trial that we're going to initiate, in June, hopefully, because we got everything set up for this, is really with this mindset. We're not affecting the mindset. I'm not giving AI to the physician in their room. They're going to do their work. They're going to come to the peer review. First thing's going to be displayed is only human-generated content. They're going to have a discussion. After that discussion takes place, we're going to turn on the AI contours, and they can compare and now have the second discussion. So you could blame me that I'm going to extend by a few minutes, the review. Yes, I'm actually creating maybe more workload on physicians. So I'm not a popular guy. But from a safety perspective, based on the results of the study, that's indicating I don't have a proof to tell you that this can be displayed together. I've seen too many risks. I've seen my results. So I am not confident to go into a clinical trial that could say that let's just put both contours at the same time. I have to first put one contour and the other, learn from that, maybe go to the lab more, and eventually run another clinical trial with more confidence and more study, more preparation, where I would put two contours at the same time. And eventually, I could argue that there will be another study and another clinical trial when we would let the physician use the tool and the AI in their own room, generate something, and then follow through. But that changes the workflow again, right? So you can see the layering and the need of studying these dynamics because we don't have data. I can't pick up a data and read a paper or go from someone else's experiences, say what is the best workflow of incorporating AI in this case in radiation oncology, right? So human factors engineering, my training tells me that I got to do these studies, and it's fascinating. It's a lot of lessons. So with this, thank you, and I will take questions and comments.
Okay. If people in the audience have questions, please go ahead and unmute yourself at any time. Let me kick it off. Oh, here we go. So, one of our students asked, do clinicians have access to the AI decision reasoning or confidence levels?
We do have that data is based on the dice score. So we use three different dice scores that gives you kind of the measurement that is now a metric that is being utilized specifically for contours, right? So that's what they have access. We do not have any other measurements that we are providing for the clinical trial.
Okay. Your approach reminds me of a book that came out a couple of years ago by a guy at Wharton, Ethan Mollick, called Co-Intelligence, How We Can Partner with AI. And he suggested very much what your approach is that AI is not something necessarily that's going to replace us immediately, but rather it may augment what we do and what we know. Do you ascribe to that approach?
No, thank you. That's an excellent comment, and thank you for bringing that up. I think we're exactly working on that. These studies that we're generating hopefully will inform, where that within healthcare space, where do we, use AI as an agent that will do the work independently of us and it will do it well, and we can trust it, and that's how maybe the healthcare system should proceed, right? Versus where the human should never lose the ability or should even be by policy required to do the work, even though there might be AI tools. And then, in the final stage is that how do we create this collaboration, right? Like, so going back to the experiment, I don't have an answer even in this work that I'm performing of what this should look like. This might be the case that for some standard cases, really standard that meet certain requirements, I would say that I would allow AI to do the work in the office by itself and we will trust it, right? But again, because it is efficient, it provides a standard, there is a trust, and there's a very well-defined group, the population of patients that we would be able to do this. And that would take some workload out of the clinic. And that would, reduce cost. That would allow for better well-being. That would, improve safety, right? Given all these indicators, right? Versus cases where that by the policy and definition would be the cases that the human, regardless if you have going to have a great indicators and measurement, that the humans have to continuously and doctors do, because that's the point of knowledge transfer to the future residents. This is a way of continue to practice medicine. This is the way we ensure long-term, some level of, just why we do this, right? Why we are even here, come to work. And of course, and then this collaboration between the two. So I'm not giving you a direct answer because I don't have one. I don't want to say yes or no. I really deeply think about these issues, and I think that's why it takes, kind of getting deep dives into the workflows and the studies before we really know. So little vague, but it's fun to think about it.
It's a situation that is in evolution. So one of our other participants asked what kind of or what type of AI was applied, and what's the name of the platform?
It's in the paper. So Brian Anderson, I don't want to butcher it. So I'm not going to give you the specifics. So our team of experts that I've introduced that build the model, the credit goes to them. And we do have a paper published on the development of the AI. So if someone is interested, happy to share, and then you can get all the specifics right. And I don't need to give you something that's incorrect. That's not my area of expertise of the development itself of the AI, algorithms that we've used here.
Um, Hi, I'm Rashika. I wanted to ask, I'm sure I could find this in the paper, but when it comes to looking at the accuracy and being able to trust in the AI output recommendations, how do you visualize that workflow from the AI side so that when these clinicians are coming together to provide their individual inputs, they can also take a look at the AI's quote unquote reasoning, if that is something that's in the works.
Yeah, I think at this stage, this is also a great question. A development of what we would call like a scorecard. So that is in the works. It's actually a new part of the study that is being done is this concept of you need to provide some level of contextualization. Is that we have this classical measure that I can display on the screen while the human generated, which again, remember, it's you could say that's at this moment it is what we believe is right the truth. We're trying to push this to clinical to so if you bring the AI counters, you do these evaluations of what is called this dice score, right? There's also Hausdorff's distance that we are using. There's volumetric versus kind of a average of distances. Like if you look at the pixelations, right? So there are classic measures. The industry use these measures for decades, right? And that's how they think. You go to conferences, you speak with the physicists. That's how they're going to think about. It's kind of like how good is this contour, right? So that's one. But my point is that what is important, and you're asking a really interesting question, is that, separately, each of them, how well each of these contours is trying to follow the guideline, the atlas, right? Because again, the human is doing it because it learned. It's not necessarily following all the guideline atlas. So we should have a score of, comparing these two, right? That's one. Then I think each of them should be compared and scored with respect to a guideline that kind of helps you like, hey, are we trying to do standard work in this clinic? Are we trying to standardize care? Are we trying to reduce the cost, right? So how far are we from this perspective? And eventually, right, which is the new work, is that I mentioned a number of times that you do have these blood vessels, a completely different way of thinking about of how we've been doing and teaching the AI. So I can tell you that right now, the AI has been trained on what? Taking contours from the clinic. Yes, there's 5 physicians. They're good physicians. They've been practicing this for a number of years. We take the training data set, we do the validation, and as we create with the model, we say the model is right, is how close to, it still comes from that training data set. Now, that data set itself, you don't know how close does it come to a guideline, right? So I could take it from Chapel Hill, UNC. I could go to Hopkins. I can go to, Mayo Clinic, Cleveland Clinic, whatever, right? There will be differences, right, of how people practice what they do. So I think the importance of your questions, that I feel is that the accuracy of the model, it is with respect to what, right? And I think the clinician needs to contextualize that if we display something else on a screen after giving them so that they can build confidence and trust, that metric of numbers that's going to be displayed on the screen needs to have a true meaning of what is being done, right? Because again, unfortunately, there's no truth. There is no truth. It's only as the best you can do. Right. So we are dealing in medicine in a lot of these times because of the variability in practices. You have this phenomena, right? That is occurring right in front of us. So long answer again, but great question.
Thank you. So as you are developing this approach, you're thinking about workflows, and as you mentioned, they do vary from place to place. Have you thought about how to introduce this so that other institutions can adopt this approach and standardize it based on their situations?
Yeah, I mean that's again, 'cause what a yes, great question. Um, I'm in the process of heading towards the clinical trial, and I really told myself again, and I'm just almost have to do this to myself when I wake up in the morning and I want to be excited about the work. We all do this, right? You get up and you're like, what am I going to do? How can I contribute? Uh, so spending a lot of time deciding on what is the clinical trial that's going to start, in June was not an easy task. It was actually mentally, and I went through a lot of thinking, like, can I push myself based on the results? Should I, we have very long discussions with, Dr. Marks and other Dr. Das and other folks here, is that has this been enough of this experiment that took us a lot of effort that we could even display two contours at the same time? And at the end, we felt like that would be not responsible. Right? They'll be not responsible. So we are doing this in this extra workload that I explained to you as that a human is going to, people will discuss in next. Now, can I ask another clinic to do that extra? Probably not. Like, am I at the place where say like, you know what, if you're going to use AI and then use our model, you can create your model, right? Your own model from your data, we can help, right? We can collaborate from the creation of the model itself. We have that expertise, but the point is asking people to do more, right? On top of everything, is this now scalable? You could argue it's not, because I'm asking people to spend maybe 3-4 extra minutes. That's a lot of time. This is peer review happens at 8:45 every single day, and it's done fairly quick. A lot of cases gets reviewed. This is the final look in the multidisciplinary. I'm asking you to stay longer. So the scalability at this moment, right? A lot of people may argue is Mazur, what are you doing? You're just adding, you're adding workload. But if we're talking truly creating safe and responsible healthcare, right? My research, I'm going to do it with the way I believe in it, right? And I'm going to contribute. But is it scalable solution because of the workflow itself right now? Maybe it's not. And it's okay with me, right? Because I still feel like maybe the results and what we're going to publish, maybe it will slow down the industry and has to think twice, because so far I'm learning that we are not mature enough in a lot of these things to just say, throw AI and it's going to do it, or we're going to just magically collaborate with the AI, right? I mean, UNC healthcare system is implementing a bridge system, and we are now in a place where, went out there a lot of things, but, there's a lot of potential, a lot of issues that are coming out, right? But we're moving, we're going, right? But there's a lot of details are coming out, and unfortunately, is it too late? I mean, why do we have patient harm because of these things? And people are extremely smart; they're doing the best thing, but I tend to wonder that a lot of this implementation and scaling is going to occur without sufficient work on human factors, implementation science, and risk. We're going to create a great algorithmic things. They're going to prove to work, and we're going to validate. It's going to be great tools, and we're going to forget to do the hard work that other industries, high reliability industries, done before getting these tools into practice. Again, great questions. Definitely a lot of thoughts in my head around these things.
That was a great answer. AI is one of those areas that is fraught economically, socially, intellectually. And I'm just kind of curious about naming it the jerk in the room. Was that to sort of put everybody at their ease that, you're identifying this new thing as a jerk, therefore they can feel somewhat emotionally superior?
Yeah, it was. Thank you for bringing that up. Yes, because it was actually Dr. Das. We have one of these meetings. We discussing the results, and it's really heated. People are, it's fun, and at some point, we are saying that a lot of times, unfortunately, of the culture, you bring residents, you bring other folks into the peer review, and you can see based on the culture, nicely that here in Radon we have a culture people will speak up, but I tend to feel like, certain people come in. there's a specific mix of people, and suddenly it's quiet. And I'm not saying there's no psychological safety to speak up and really say, but there's definitely some pressures, right? You new to the department, you are a resident, and you see something on the screen, the difference, and you like, but the cases of a Dr. X, and Dr. X is so known and he's so big and he wrote 5 books, and I don't know if I can say it, right? So you have these dynamics that definitely is going to be present, you want it or not, in the room. So we felt like, the word jerk came because the jerk will always say, it's always there. It always got an opinion. So we just, the name came through this discussion about, how people will really speak up when they see a AI generated contour, because it's sometimes not easy, right? So the jerk kind of came through these discussions. They're like, look, the jerk will do it. The jerk will say it. So that's kind of the name, the little history of the name.
But it does seem like there's a functional purpose and benefit of the AI participating, because by calling it a jerk, by putting it into that particular box, you give an opportunity for people to trust this a little bit more than they might otherwise. Is that a valid way to look at it?
Yeah, we will try, right? The name I think stuck too. People kind of liked it, so I think that also was good that we felt like even as we are preparing to the clinical trial, like that, it gave some humor, relaxed people a little bit. That we have a jerk and there's it's gonna be this AI thing out there, right? So it's almost like creating a persona of it, right? Like creating a character that now it's something that's going to be partnership, partnering with us, right? And we gave a little name like this. Yeah, right. So it's yeah, it's a great discussion. Yes.
So let me remind everybody, if they have questions, jump in, please. We'll give everybody a few seconds.
Yeah. If you, as you guys think, I have a question to the group, right? If you guys don't mind, I know it's always me answering, but I hope you guys got something out of this. But I do want to ask folks, if you don't mind sharing, is that what do you currently, what do you think? What do you see about being done, and what potentially worries you about exactly the integration, right? How much work do you believe we're doing? Are we doing enough? And if if there are some examples about truly going into right where the rubber meets the road, what do we do with that stuff? So I would love to kind of get your opinion about, where you sit with this, with all of this topic.
I'm happy to start. I mean, part of what I like about your approach is you're taking it as though, well, as it is a clinical trial. The idea there is to, essentially understand the safety and efficacy of whatever the approach might be, that biotechnology, or in this case, actual silicon technology. And we've seen a great deal of rushing forward by AI companies and others to implement self-driving automobiles and things like that, that essentially give free rein to those who are wielding these AI platforms, but not necessarily giving us a little moment of pause to determine, is this really wise, or are we doing this in the wisest way?
Yeah.
And Deborah Swain, you had your hand up.
Thank you, David, for sharing. Yeah, that's a great analogy, looking at also that industry and how that's happening. Thank you.
Yes, in lots of industries that I've worked in, human factors is very important. I'm glad you brought that up, and you're including that as well as risk analysis. Do you have a specific plan for the upcoming in June to have human factors added or applied?
Yeah, I mean, and thank you for sharing. Yes, Deborah. Yes, so we will continue. It will be, we will attend all of the sessions. There is exactly a framework that really goes with the implementation, and there's us as human factors engineers collecting the data, monitoring, every single case, every single thing. It's being kind of extremely proactive on the implementation, risk, and human factors during the time of the clinical trial, right? So that needs to be, because I'm very, I don't want anything to go. I mean, I'm afraid almost something can go wrong, right? These are real patients. I mean, it's my responsibility. I feel like partially now I'm responsible for changing the workflow, bringing AI in, and I can't think that there will be some sort of a safety, right, a compromise in this case. Yeah.
Thank you. Very reassuring.
Yeah. Oh, there's.
Hang on, we got one coming up.
Okay.
I think the biggest thing is just having that transparency available in terms of having very clear frameworks to go by with whichever role you're in, having like that step by step. This is why this is happening. This is what you need to do and why. I think having those contexts available and easily accessible is the biggest thing as AI becomes more centered in our workflow.
Okay. Yeah, I mean and when you think about frameworks, do you have something in particular in mind too, like on your end? Like I think about approaches, right, to this, like we've mentioned with Deborah, like you can look at it from human factors, from risk, from those are approaches, the mindset, and then you bring different frameworks and tools in from them as you're building up, this. Do you have some ideas about like the specific frameworks that you like or you would see, as a good fit here?
In particular, the frameworks, of course, that are focused on human-centered design, focusing on the problems that you need to solve and go like step by step, breaking it down like that, really.
Yeah, human-centered design, such a wealth, right? Such a wealth of knowledge in these frameworks. Yes, thank you so much for sharing.
Stefan, you have a question.
Yeah, no, just wanna say a comment. I mean, I am a physician, so one of the things that comes to my mind first when you use this kind of technology, I think it's a problem that we have been with not just AI, but with other technologies in general. So the problem is, for example, the old doctors, at least in my country, say in our times, we just rely on the symptoms and things, and you are not relying on new technology, for example, new tests, including lab tests, including image tests, and you are like not really thinking about the patient, but just like over reliances technology for do diagnosis or for do treatments, for example. And I think AI is like another layer on this. Like is okay. So I think so for me, for the clinical side, I think I think the purpose of the use of AI and I think in general technologies is to try to find a sweet spot between over reliance and confidence. So like when I can trust on this technology, but I have enough training to not over rely on the technology I can use this for the good. I mean for improve my work and not for do less work and like this could implies a danger for patient because I'm over relying on technology.
Yeah. And again, I think Stefan, thank you for bringing that up and then sharing. And just I think exactly, and you look at it from also different perspective as you practice medicine, in different countries around the world. Um, the also the things that from confidence, over reliance, these things, they not necessarily going to come from all of it from the experimental things we do doing human factors, user-centered designs. As we are leading to that moment where we are implementing, we're going in the real world. So some of these things you mentioned as a implementation science metric, I think they're really critical. Like we're going to have to start thinking about that these are indicators of safety and integration, and not just the indicators of implementation itself, right? So the argument, that I feel like even hearing is that we need to start reconceptualizing about each phase of what really safety means here, right? In this workflow. So I appreciate you sharing your thoughts. Yes.
Well, looks like we are out of time. This has been an excellent presentation and conversation. Professor Mazur, thank you very much for leading this.
Thank you guys for the opportunity. I hope it was useful.
And thank you, David, for a great semester.
Welcome. I look forward to seeing everybody in the fall.
Thank you. Bye.